President API, Dr. KAMLESH TIWARY and Dr. Dean, Dr. RAJESH UPADHYAY, can we start the meeting, sir?
Yes, sir. Go ahead.
Yes. Friends, I extend a very warm welcome to you on behalf of Scientific Committee Society and Rajasthan Forum of ICP Fellows on today's ICP CME, which is being organized by Indian College of Physicians and academic wing of API. Today we'll discuss an important but often neglected clinical entity, orthostatic hypotension or postural hypotension, which is encountered very frequently in our clinical practice. It's my proud privilege to welcome our distinguished guest and faculty of today's evening, all our stalwarts of API and ICP. I extend a very warm welcome to our mentor and guide and veteran of API, Dr. YP MUNJAL sir. I'm highly grateful to Dr. YP MUNJAL sir for his generosity to spare his valuable time to attend our programs very regularly. I am grateful to our leader, Dr. PAREEK sir, for his very valuable guidance and blessings at every scientific deliberation which we plan at Rajasthan API. I take pleasure to welcome our energetic president, Dr. KAMLESH TIWARY sir. We trouble him very frequently, and I'm grateful that he accepts our request every time and spares his valuable time to attend our program. I welcome Dean ICP, Dr. RAJESH UPADHYAY, a man of versatile leadership qualities and human values. He has spearheaded the academic movement across the country under the banner of ICP. I welcome faculty of the evening, Dr. MANGESH TIWASKAR, the dynamic secretary of API, Dr. JYOTIRMOY Paul, Dean-elect ICP, Dr. NP Singh, Member Faculty Council ICP, and our chairpersons, Dr. PANELISTS, Vice President-elect API, Dr. Ravikeeryyhy, Member Governing Body. I have a special word of gratitude to Dr. MANGESH TIWASKAR actually. Dr. G.S. Wander was supposed to deliver this talk on postural hypertension, orthostatic hypotension, but due to some health reasons, he could not join. I requested Mangesh only yesterday, and he prepared the topic and came to our rescue. Thank you, Mangesh. I welcome moderators, Dr. G.D. Ramchandani and Dr. PRADYUMN Sharma, pillars of Rajasthan API and key persons of every scientific program which we plan. And I extend my very warm welcome to all the attendees who are attending this program. Your presence is the key to success of this program. At the outset, I request Dr. PAREEK sir for his welcome note. Sir, please unmute yourself. Please unmute, sir. Please unmute, sir. You are muted.
Good evening, everybody, and warm welcome to everyone. Dr. YP MUNJAL, chief guest of today's CME program, my mentor and guide, Dr. KAMLESH TIWARY, dynamic president of API, Dr. RAJESH UPADHYAY, Dean ICP, our chairpersons, Dr. JYOTIRMOY Paul, Dr. PALANIAPPAN, and Dr. Ravikeeryyhy, member governing body, our program director, Dr. GIRISH MATHUR, president-elect of API, our very energetic honorary secretary of API and a dynamic speaker, orator, Dr. MANGESH TIWARY, Dr. MANGESH TIWASKAR, sorry. I extend my sincere thanks and gratitude for accepting our request to speak on the subject. Our moderator, Dr. PRADYUMN Sharma, pillar of this CME program, and Dr. G.D. Ramchandani, all delegates who are attending today's function. Friends, we know that orthostatic hypertension, as Girish said, that it is most neglected, understudied, and often underappreciated in clinical practice because of unfamiliarity with this orthostatic hypertension, which we see many times every day in our practice. We have got a very renowned orator, Dr. MANGESH TIWASKAR, to give an insight of everything about orthostatic hypotension, what is orthostatic, what is the clinical symptoms, what is workup for this. So I again thank you, Dr. Tiwaskar, Dr. MUNJAL sir, Dr. Rajesh UPADHYAY, and all the guests today, our chairpersons, moderator, Dr. N.P. Singh, a very eminent nephrologist of the country. So thank you everybody for sparing your valuable time. So over to Girish for the proceedings.
Thank you, sir. I now request Dean, Indian College of Physicians, Dr. Rajesh UPADHYAY, our special guest, for his words of blessings.
Thank you very much. It is great to be again amongst all the stalwarts of API. I must say that this year has been an incredible year for the ICP. And who made it incredible? And when I look at the pictures in front of me, I see all the stalwarts who have really contributed so well to provide impressive educational programs throughout the country. In the north, we have our very senior leader, Dr. PAREEK, and my very dear friend, Dr. GIRISH, who have been very, very active, and they have been doing programs day in and day out. And I'm really thankful to you for having conducted this and given impetus for others also to continue. On the Eastern Front, we have our very dynamic president, Dr. KAMLESH, who has really gone at a very rapid rate, and he has conducted all sorts of programs which has really gone a long way in the educational arena. So I really thank Dr. KAMLESH TEWARY for having done that. On the other Eastern Front, which is the Bengal, Dr. JYOTIRMOY is there, sitting there, along with Professor M.K. Roy. They have been doing a great work. And the moment we started the project, they really jumped in, and they have been going at a very steady pace and conducting their programs at a very, very steady pace for the last 2.5 years or so now. So again, my sincere thanks to JYOTIRMOY and Professor M.K. Roy for having contributed such a lot to the ICP programs. And then my very dear dynamic young man friend from South, Dr. Palaniappan, he all went at a very rapid rate. He went at a very super fast rate. And he was conducting not one but two programs per week. And really, I must say my sincere thanks to all of you for having done this, because we are all doing it because it is our association, it is our college, and we are doing this to expand the knowledge. And therefore, we are doing a great thing, particularly in the difficult times. We have really managed to convert the adversity of COVID into a real opportunity, which we are seeing today. Dr. Girish, I looked at today's program and I was really impressed. Orthostatic hypertension is a very interesting area. And although I thought it was Dr. Wander speaking, but I am more than happy that our very dear friend and very dynamic Honorary General Secretary Mangesh is there. Mangesh is a great academic person, a person with a great oratory skill, and he is a human being and a very good friend of mine. So I congratulate you for organizing this program, and I'm sure it will be a great program, a great learning for everyone. Thank you very much. I'm sorry I've taken a little more of the time.
Thank you, Dr. Rajesh. I request our dynamic president, Dr. Mangesh Tiwaskar wants to say something. Mangesh?
No, perfectly fine. I'm
Okay,
truly
actually,
touched.
you raise your hand.
No, it was it was clapping actually.
Okay. I request our dynamic president, Dr. KAMLESH TEWARY.
Thank you, GIRISH. Thank you very much. Respected our chief guest, Dr. MUNJAL, our guardian, Dr. K.K. PAREEK, and all my fellow colleagues present here. I am very happy to see this program or this type of program because we were involved in such type of program from the very beginning, and it is initiated by not other than our Dean Dr. Rajesh UPADHYAY. So all credit goes to him. He has initiated and we are propagating it. Anyway, it is going in a very nice way and it is a successful program going out throughout the country. I am obliged and thankful to organizing team who has invited me for this program, and I will bless that this program should be nice and beneficial for postgraduate students. Thank you very much. Thank you.
Thank you, sir. Thank you so much. I request our senior most leader, mentor and guide, Dr. YP MUNJAL sir, for his words of wisdom.
Sir, you need to unmute yourself, sir.
Sir, you are muted, sir. Please unmute. Thank you, sir.
Is that all right?
Yes, sir.
Yes, sir.
Dr. Girish Mathur, the coordinator of this program, under the very able leadership of Dr. K.K. PAREEK, I can tell you that this sort of program was being held by the Kota chapter of API from the time I have joined Association of Physicians of India. And it was to the credit of Dr. PAREEK along with Dr. Goel, who were spearheading this program of CMEs for the people and by the experts in that particular field. They are still on that track with a vengeance, and they are carrying on this program for the benefit of practicing doctors as well as students. So my compliments to them. I must say that Dr. Kamlesh Tiwary is a dynamic president. Before anybody could think of, he plunged himself into the program and motivated the people and friends from Bihar to conduct this program. The Eastern Zone, represented today by Dr. JYOTIRMOY Paul, I can tell you that he is a dynamic personality who conducts these programs so meticulously and so efficiently that they are a source of respect as well as learning to all of us. I think the basic idea which came to Dr. Rajesh Upadhyay, our Honorable Dean, to take up this issue was from the program of Dr. JYOTIRMOY Paul. The West Bengal chapter of API was holding 1 month of concentrated medical education for the postgraduate students, and seeing them conduct this, I think the good sense prevailed, and the president and the dean took upon themselves to carry out this objective. To the dynamic leadership of Dr. K.K. Pareek, who not only has led by example, but has motivated people like Dr. GIRISH, MATHUR, Dr. RAMCHANDANI, Dr. SHARMA, and many others into the action program of API. And I think Rajasthan is blessed to have a son like Dr. K.K. Pareek. Before I conclude, I think the effect of hypertension takes a long time to come, but hypotension produces the symptoms as well as effects very rapidly. And therefore, today's speaker, who has rapidly agreed to be part of this deliberation, Dr. Tiwaskar, needs our thanks and compliments for having taken upon himself this job. I think already Dr. Rajesh Upadhyay has given the tributes to Dr. JYOTIRMOY Paul and the other friends who are spearheading this movement. May God bless, and this movement should continue. And I'm grateful to the Rajasthan chapter for inviting me to be part of the excellent CMEs which they have organized. Thank you very much.
Thank you so much, sir. We are blessed by your gracious presence. I welcome our distinguished chairpersons, Dr. Palaniappan, Dr. Ravikirti. Dr. JYOTIRMOY Paul will join as a panelist as there is some change in the program. So I request Dr. G.D. Ramchandani to please introduce our distinguished chairpersons.
Thank you, Dr. Girish Mathur, sir. It's my proud privilege and honor for me to introduce both the speakers, both the chairpersons. Dr. Palaniappan, as rightly said, is the young, dynamic, rising star of API and is the vice president-elect of API. He is the managing director of 50-bedded hospital at Dindigul, Tamil Nadu, and is a national API governing body member of 2019 to 2022 and recently also from 14 to 17. And he is organizing very popular Tamil Nadu state chapter of API conference for the last 5 years, and is a scientific committee chairman of TEPICON 2020, 18 and 2011. He is a co-opted member and joint secretary of Hypertension Society of India for the 2015 to 17 and editor of TEPICON Medicine Update book for the 2 times, 2018 and 2011, and received the prestigious 2017 Alumni Award from PSG and Sons Charities Coimbatore, and is in many publications in various national and international repute journals and books also, and is a young dynamic speaker of the various national conferences of this national and state level, and one of the editorial board member of TAPIJ, and he introduced 10 gold medal for MD PG students in Tamil Nadu and Pondicherry API since 2011. So I request, I invite Dr. Palaniappan for today's session. And our next chairperson is none other than Dr. RAVIKEERYHY. Dr. RAVIKEERYHY is the Director of Internal Medicine, Kaveri Hospital and V2K Specialty Clinic, and he is a governing body member of APA since 2020 till 2023, and a joint secretary of ICP Dean's Place 2018 and 19, and joint organizing secretary of Epicon 2018. He is a past secretary of Treasurer of and EC member of APA Karnataka chapter, life member of various bodies of national and post teaching faculty of BMC and RI Bangaluru at Kolar, and past consultant physician Manipal Hospital, BGS Global Hospital and NMC Hospital Abu Dhabi. So I invite both the chairpersons for today's CME. Thank you for coming, sir. Thank you very much. Over to Dr. Girish, sir.
Dr. Palaniappan, please invite Speaker Dr. Mangesh Tiwaskar and introduce him.
Yeah. Can you share the slide? Can you share the slide, Grace?
That's okay, Palani. That's okay. Just that's fine. That's fine.
TV has been sent to you, Palani.
Yeah. Thank you so much, Dr. Grace, Dr. KK PAREEK, sir, my dear friend, Dr. Ramachandani, for giving me this opportunity. Today, the speaker is none other than my dear friend, Dr. Mangesh Tiwaskar. We are going to, Mangesh Tiwaskar is the dynamic Honorary General Secretary of National API, ICP and PRF. He is doing lot of programs. He is ready to accept immediately within one day. He is having a lot of topics. He has delivered a lot of topics in various fields in general medicine. My heartiest welcome to my dear friend, Dr. Mangesh Tiwaskar. He has published various published in various journals and regular speaker in Epicon and various state chapters, and he has published in Intex journal. My heartiest welcome to my dear friend Dr. Mangesh Tiwaskar. Today's topic is orthostatic hypotension, often neglected topic. If you neglect, you will get a lot of mortality, because orthostatic hypotension is very important topic. When I did PG, a lot of patients we used to see in nephrology, usually they lost the definition of orthostatic hypotension and otherwise called postural hypotension, mostly often neglected due to dehydration, hyponatremia, due to aging. Sudden changing position can kill the patient. And dengue fever, many patients due to orthostatic hypotension, we may lose the patient. Nowadays, during COVID era, also orthostatic hypotension, and there are a lot of things, that is food during feeding hypoxia, bathroom toilet hypoxia, like that, you are losing many people. So orthostatic hypotension is a very important topic. 20 millimeter and 10 millimeter, 3 to 5 minutes. It's a very important thing. So all the things, what all the causes, how to evaluate and how to manage high index of suspicion is very important. It's a hit hard and hit fast pull has to be applied to manage orthostatic hypotension. Over to my dear friend, Dr. Mangesh Tiwaskar, to the topic proper.
Thank you, Dr. Palani, and thank you, everybody. Good evening, and I bring all of you greetings. I hope I'm audible.
Yes.
Yeah, thank you very much. And my sincere gratitudes and thanks and the opportunity given to me by Dr. Girish, MATHUR and the entire team of Rajasthan College of Indian Chapter of Physicians. And of course, to all my stalwarts, my seniors, I seek your blessings. And I also wish all the people, those who have joined and spared their evenings, very good evening. And also, I wish all of you a very happy Ganesh Chaturthi. Now, before I start deliberating, it was I would say an attempt, to try and give you an overview of what orthostatic hypotension. This talk was, as Girish has already alluded to, was supposed to be delivered by one of the great cardiologists of our country, Professor Dr. Wonder Sir. As he is unwell, I wish him also a very speedy recovery, and we all wish him a very speedy recovery. Now, as probably Dr. Munjal sir has already spoken, and Dr. KK Parikh has talked to us that orthostatic hypotension is not a very favorite topic of the conferences or the stages scientific forums. This is my declaration of the full disclosure that I'm going to discuss the guidances usually based on the NIH, ACC and ESC guidelines. There are no product biases involved here. And of course, there are no financial gains. Now, it's very interesting to know that cardio-postural interaction, the changes that happen and the accommodation and adjustments, the whole circulation, including the peripheral perfusion, actually undergoes. It's a very complex reaction. We all are aware about it. There are so many things which are involved. There are, am I supposed to? Okay, so there are so many things which are involved. There are so many systems which are involved. There are, as we all know that, as we have an involvement of a cardiovascular system, we do have got a involvement of an autonomous nervous system. There is a big role to play of the skeletal system. And of course, along with that, the somatosensory, the vestibular, the visual stimuli, the motor functions, the muscle functions, everything comes into the picture and action when it comes to the adjustments. And we all know that the postural hemodynamics is a very, very tricky thing. The moment you get up from a lying down position, within first second, usually to 1 minute, there is usually the pooling of the blood happens. And then up to 30 minutes, if you keep on standing slowly over a period of time, there is a plasma perfusion happening into the third space. The various mechanisms which are involved, and that involves autonomic response as well as the endocrine response. I'm going to go a bit details on this when I'm talking to you about an overall compensatory response whenever it comes to the postural adjustment. So the moment you stand up from the lying down position, the mean arterial pressure, we all know, goes down. Now that does what? That actually reduces down the baroreceptor stretch, where they are usually placed in the arch of the aorta as well as the both carotids. So carotid and aortic baroreceptor stretch goes down, they get stimulated. The baroreceptor activity starts going down, which slows down the parasympathetic nervous triggers through the glossopharyngeal and vagal nerves, and which are responsible for increasing the sympathetic drive and reduction of the parasympathetic drive. Now that leads to what? That leads to increase in the stroke volume by improving the cardiac muscle contractility. The heart rate goes up basically, and there is going to be an increase in the peripheral vascular resistance because of the arteriolar constriction that you are going to have. Also similarly, there is an increase in the venous tone that causes increase in the venous rhythm. So in total, there is increased sympathetic drive and there is a reduction in the parasympathetic drive, which increases the cardiac output, and the mean arterial pressure, which is usually down, it quickly regains back to normal and we do not even realize it. So that happens very fast. But whenever there is a cardiovascular dysregulation happening, it can sway in both ways. If it turns right, then you get hypertension or a labile high blood pressure. But if it turns left, then there are three phases or the three problems that you can encounter. The first one we classically know as a vasovagal syncope or the neurally mediated syncope. The second one, which we popularly see, and as Dr. Palaniappan was also talking about, is the COVID challenge, which is usually very common in the post-COVID phase, is what we know it as POTS or OTS, that is orthostatic tachycardia or the postural orthostatic tachycardia syndrome. And then we also get something which we are going to discuss today is orthostatic hypotension. And so let's talk a bit about orthostatic hypotension. By definition, as Dr. Palani has already briefed, it is the fall in the systolic blood pressure by more than 20 or the diastolic blood pressure and or both, I should say, diastolic blood pressure by more than 10 millimeters of mercury within first 3 minutes of standing after the minimum lying down of 5 minutes. Now, this is very important for us to understand all these words in this definition. Or whenever the patient is submitted to a tilt test at the angle of 60 to 70, whenever there is a fall in the systolic, and this is true for the normotensive patients. But in the hypertensive patients, the cutoff is usually 30 millimeters of fall in the systolic blood pressure, which may be more appropriate. And this is according to the latest ESC guidelines which are published. And why it is so? Because we have to understand that blood pressure fall after standing up largely dependent is dependent on the baseline blood pressure. And that is the reason why in hypertensives, the systolic cutoff is usually more than 30 millimeters. And usually when you consider the fall of more than 30 millimeters, the chances of recording the false hypotension or a false orthostatic hypotension goes down to nearly 1%. How do you do it? How do you measure the orthostatic hypotension? First step, you need to make the patient lie down for minimum 5 minutes flat, either on the bed or on the table or on the sofa, whatever the place you are comfortable with and the patient is comfortable with. And you need to measure the blood pressure accurately with the correct technique. After that, record the blood pressure reading. Once you have done that, then ask the patient to get up and ask the patient to stand up straightway, but give him or offer him or her your support and check out whether the patient is able to stay stable. If the patient is swaying or becomes symptomatic, you need to offer him or her the support, remember that. And try and measure the blood pressure within first minute. That is called as the first measurement. And then later on, after exactly 2 minutes, the second reading is usually done. And record all the 3 readings and then analyze it. But very important to understand and note that the condition is diagnosed based on the first minute standing blood pressure recording and not the third minute. Remember that. The third minute is only simply to get an idea how quickly the patient is recovering and the body reflexes are, again triggering back, and how the mean arterial blood pressure or the blood pressure is bouncing back to normalcy. It is also important to note that regardless sometimes of the BP values, if the person feels lightheaded, dizzy, consistently upon standing, the diagnosis of orthostatic hypotension can still be made. Now, this is again based on the latest European Society of Cardiology guidelines 2019, and they have also suggested that a persistent drop of systolic blood pressure to less than 90 millimeters should also be considered as an orthostatic hypotension. And this is what the classic thing which is happening. You can see the tracing, the sphygmomanometric tracing of the blood pressure recording, and you can see this is a classic case of orthostatic hypotension. And this is another case where she is a 52 years old lady who has been recorded, and a BP tracing was done along with the heart rate tracing, and you can clearly see that within 3 minutes the blood pressure went down significantly, probably from 170 to straightway below 90 or below 100. So that is what the orthostatic hypotension is. And the specialty is that, look at this, most of the patients, those who have got orthostatic hypotension, will have symptomatic hypotension whenever they get up, but quite a few of them also has, and I appreciate the presence of and the interest shown by Dr. NP Singh here in this topic, because I know that I'm very aware that whenever I have shared diets with him a couple of times, he is always very passionate about the blood pressure and the related challenges. And he'll also appreciate that majority of the patients have additionally what we know as a supine reversal of the circadian rhythm causing hypertension. So they develop supine hypertension, and they also have the symptomatic hypotension on the getting up or after the orthostasis. What is the epidemiology? Usually the prevalence usually increases with the age, and mostly you'll find out that the patients above the age of 70 years, as Dr. Palaniappan was talking about, 30% of the people will have orthostatic hypotension. There is no gender bias recorded. Now, how do you classify orthostatic hypotension? There are various classifications, but the commonest one is neurogenic orthostatic hypotension. So technically, you can classify them in 2 broad groups, neurogenic and non-neurogenic. Sometimes Neurology Society of America tends to classify them like that, where you have got a sympathetic adrenergic nerves continuously failing to facilitate the reflex cardiovascular response. So there are both failures, the autonomous failure as well as the peripheral nervous system failure, to cause the rise in the blood pressure leading to an orthostasis. And that is where probably the way the classical description or the definition of orthostatic hypotension has come. But there is some very interesting entity which is usually seen in young adolescent patient, which is called as initial orthostatic hypotension or IOH, where there is a rapid brief fall of systolic blood pressure by nearly 40 millimeters systolic or above, or diastole goes down by more than 20 millimeters within first 5 seconds to 15 seconds. But it immediately reverses back within to normal limits after standing within 20 seconds. Now, this is called as initial orthostatic hypotension. And this is what we call it as an exaggerated compensatory mechanisms, which are not, patients may not become symptomatic for this initial orthostatic hypotension. Now, if the orthostatic hypotension persists beyond 3 minutes, then that is called as a delayed orthostatic hypotension. Then there are neurally mediated syncope, or what we also classically know as vasovagal syncope, where the parasympathetic nervous system inhibition fails to get inhibited and patients develop a syncope. Along with that, there is a fall in the blood pressure, there is a bradycardia, and sometimes you may develop arrhythmias. This is sometimes commonest reason for the elderly to collapse into the bathrooms, or while they go for either an acute change of the posture or sometimes visiting the bathrooms. Lastly, there is what we know as a cardiovascular orthostatic hypotension. We all have been aware about that. These are secondary to the cardiovascular conditions. And one aspect of this is what we know as POTS, paroxysmal orthostatic tachycardia syndrome, or OTS, orthostatic tachycardia syndrome. This is similar to the orthostatic hypotension. And lastly, I would say that orthostatic hypotension, which is a pseudo hypotension, which could be primarily because the hypotension, you have not measured it correctly, or the patient already has got something called as a labile hypertension, and you have not actually taken the reading properly, or the patient has so much of fluctuating blood pressure that it is very difficult to record even the baseline blood pressure. That time it is quite possible to get orthostatic pseudo hypotension. There is another way of classification that is depending on the functional disabilities. Class 1 is usually asymptomatic people. The events are very, very rare, and the symptoms like syncope or pre-syncope or occasional falls are very, very rare, occasionally once in a year. Then class 2, the symptoms, they become more sporadic, the frequency goes up, probably irregular symptoms in extreme conditions like very high amount of exposure to cold, or the extremes of temperature, or sometimes in the changing atmospheres, these patients, they develop this. Class 3, the symptoms, they become more frequent, more vigilant, but also here now it starts causing the limitation of the daily activities, or quality of life gets impacted. And lastly is class 4, is the daily persistent severe syncopes that the patients, they keep on getting, causing not only the affection of the quality of life, but also changes in the cognition. So what are overall causes of orthostatic hypotension? Cardiac, like coronary or ischemic heart disease, arrhythmias, congestive heart failure, myocarditis as we get in COVID, pericarditis, valvular heart disease. We all know that aortic stenosis is one of the classic valvular diseases where you can expect the patient to develop orthostatic hypotension. Similarly, aortic regurgitation, also you can expect orthostatic hypotension. Intravenous volume depletion because of the blood loss or dehydration, sometimes diuretics or some kinds of anemias can cause a challenge. Venous pooling, that means usually that happens usually in the chronically bedridden patients, or patients those who have varicose veins or venous insufficiencies, or sometimes in the pregnancy, a physiological condition. Majority of the times it is the autonomic nervous challenge, which is basically what we know as the primary disorders or the secondary disorders. Primary is what we know as the pure autonomic failure or multi-system atrophy, where there is an atrophy or a dysfunction of the autonomous nervous system, and it is a classical neurological condition. I'm not going into the details about it, but it will primarily manifest as one of the prime causes of orthostatic hypotension. Secondary causes, like secondary to the chronic diseases like diabetes, amyloidosis, sarcoidosis, renal failure, we all know about it. Endocrine insufficiencies like adrenal insufficiencies, diabetes insipidus, hypoaldosteronism, FUOS, hypokalemia, we are all aware about it, including hypothyroidism, remember that. And few miscellaneous causes, like sometimes in AIDS, in some psychiatric disorders like anxiety, panic disorder, extreme excitation. You might have seen some of the patients coming to your clinic saying that there was a fight at the house, suddenly the blood pressure has changed and the patient fell down immediately. This happens very, very commonly in situations. Or something called as a postprandial hypotension, that is after usually the heavy meals, as there is a splanchnic blood flow dilatation, the whole blood pooling happens into the splanchnic circulation, and there is a fall in the blood pressure, that is the postprandial hypotension. the medications are one of the most prime things that you should be knowing, and I want you all guys to pay a little bit attention on the list of the medications. I have not put all the medications which are responsible, but these are few common medications which can cause the orthostatic hypotension, like alpha blockers, very important, especially the drugs which are used to treat prostatic hypertrophies, terazosin, prazosin, doxazocin, very important for us. Antipsychotics, TCAs, SNRIs, MAOs, clonazepam, olanzapine. These are all the drugs which can cause orthostatic hypotension. As antihistaminics, remember that cetirizine and pheniramin maleate are the commonest drugs which can induce orthostatic hypotension. So very carefully, you should initiate these therapies in the elderly, especially, and especially the frail, fragile elderly. You should be very careful. Even the drugs like ACEs and ARBs, or even the DHP type of calcium channel blockers or nitrates, remember that they can cause, even a phosphodiesterase inhibitor, PDE5 inhibitors like sildenafil can cause orthostatic hypotension. Diuretics and SGLT2 inhibitors, we all are aware about it because they cause volume depletion. Then sympathetic blockers like beta blockers, especially the first generation beta blockers or earlier generation beta blockers, can be responsible for causation of the orthostatic hypotension. Drugs like clonidine, alpha blocker, or ganglion blocker can cause a challenge. In the management of Parkinson's disease, the drugs used like alpha dopa, even remember that alpha dopa replacement drug is also a therapeutic modality for the management of orthostatic hypotension. I'm going to speak about it. But drugs like selegiline or even alcohol, antivirals, remember, especially in the COVID times, favipiravir or remdesivir can cause orthostatic hypotension. Opiates, muscle relaxants, gabapentin, anti-cancer drugs like vincristine, vinblastine, these are the drugs which are responsible for causing orthostatic hypotension. And they cause what? Complications because of orthostatic hypotension. We must be aware about it. And the commonest complication is recurrent fall. Apart from that, there is a risk of increase in the all-cause as well as the cardiovascular mortality. And this is the reason why many of times, our patients, they develop what we know as the micturition syncope. One of the causes is orthostatic hypotension because of the vasovagal overdrive that happens while micturition, and failure to have or to trigger the sympathetic compensatory response to this vagal overdrive causes an acute cardiac arrest. Cognitive decline and dementia is very common. Along with that, it actually impacts the quality of the life of especially elderly people. They feel less confident. They develop anxiety, they develop depression. That is very important for us to understand. And hence, when you are diagnosing this, a detailed history, including the food history, the family history, the drug history, always ask your elderly patients to get their medication boxes. They may be on multiple therapies. Even some of the Ayurvedic or homeopathic medications could be responsible for causation of the orthostatic hypotension. So always check for the medications. And a detailed general examination and a systemic examination is extremely important. And then correctly measure the postural blood pressure. It is very important. The commonest symptoms are usually lightheadedness, weakness, tiredness, blurring of vision, tinnitus, vertigo, headache, and pallor are the commonest symptoms. So there are questionnaires which are there, and which are the standard questionnaires which have been issued by the American Cardiology Society as well as the NIH, that you should ask these questionnaires, and these are called as the screening questionnaires. So either question specific, like do you get fainting attacks or blackouts? Do you feel dizzy? Are there any visual disturbances? And so on and so forth. There are almost 10 questions in this questionnaire. Or there can be a questionnaire based on the symptoms which can affect the composite of the activity or the symptoms of the daily activity, like whether it happens on the short time standing or a long time standing, or whether it happens while walking for the short distances or not. So these are all called as the orthostatic questionnaires, hypotension questionnaire, and you should be all aware about this questionnaire, which are there available for all of us. How do you investigate? Naturally, along with CBC, the basic metabolic panel has to be done. Along with that, serum electrolytes, remember that hyponatremia, hypokalemia are commonest causes. Blood glucose estimation along with the renal function assessment, thyroid, cortisol, electrocardiogram, 2D echo, and sometimes in few rare cases, even the radio imaging along with CT MRIs. Remember that there is no role of chest X-ray and any other much of the investigations for this. And by doing all these things, look at this entire table. I've tried to put on all those symptoms and the investigations to give you a broad differential diagnosis between the various types of orthostatic hypotension. And I would like you guys to take the snapshot of this table. I'm not going to go into the details about it, but almost if you try and fill in everything possibly by asking the patients in this table, I am sure that you will surely reach not only the diagnosis of OH, but what type of the orthostatic hypotension the patient has can be easily judged by just looking at this entire table. Treatment, finally. Asymptomatic hypotension is very common and does not require any treatment. See, people those are not symptomatic do not require, and there are no target BP goals to be achieved in orthostatic hypotension. The main treatment is usually to alleviate the symptoms, to prevent the fall, and try and stop the patient from developing what we call it as an elevated supine hypertension. So the treatment is primarily focused on mainly the lifestyle modification, and then comes the pharmacotherapy. Always remember that the education and the non-pharmacological interventions are the cornerstone of this step ladder approach to the management of orthostatic hypertension. And that is, first, always do a most important job to be done, medication reviews. Check for the medication, because more than 90% of the times, these are the medications which are responsible for this orthostatic hypotension. And then non-pharmacological measures like fluid replacement, salt intake, tight garments, exercise like swimming, and the cross-leg exercise. I'm going to show you that. And then comes the pharmacological interventions and the combination of the pharmacological agents. So what are the non-pharmacological interventions? Education, cessation of the drugs, those which can lead to orthostatic hypotension. Avoid the factors which can aggravate orthostatic hypotension, like exposure to extreme heat or even alcohol intake. Remember that. And large meals, as we have discussed, can be responsible for orthostatic hypotension. These are various, I would say, gadgets which will help you to offer the non-pharmacological interventions like elastic stockings, or the physical maneuvers like leg crossing or toe raising or bending into the waist, or the contraction of certain groups of the muscles, or there's something called as a head up tilt slipping, and I'm going to show you the photographs of this. And of course, the measures to increase the intravascular volume. One such is to ask the patient to drink rapidly around a half liter of water, and that has to be a cold water. That is one of the best measures that has been found very, very effective. And of course, assure that minimum 6 grams of salt is usually consumed by the patient. Now, this is the classical photograph of an elastic stocking, which has to be always up to the waist high. Remember that. This is the head elevated, by at least 4 inches slipping position. Or these are the various exercises, as you can appreciate, that there is rising on the toes, or cross leg standing, or bending in, or squatting, or even swimming or cycling is one of beautiful exercises or physical maneuver which can really help you in preventing orthostatic hypotension. There are various pharmacological agents. The commonest ones are midodrine, which is a direct alpha-1 receptor adrenoreceptor agonist, usually very well tested, but it's not been proved to be very effective. So efficacy is questionable. Droxidopa is a hydroxylated dopamine, which is a norepinephrine precursor. Usually what happens is that droxidopa gets converted while metabolizing into the noradrenaline, which is responsible for the sympathetic stimulation. Widely used, unfortunately off-label, but recently US FDA has approved it for the treatment of management of orthostatic hypotension. Pyridostigmine or physostigmine, we all know that it is an acetylcholinesterase inhibitor. We use most of the times in managing the neurotoxic snake bites. Generally, it is very, very effective in managing the neurogenic orthostatic hypotension only. Remember that it's a very mild drug. The blood pressure doesn't go up significantly, and its efficacy is still questionable. The commonest drug which is commonly used in absence of cardiac failure or presence of hypertension is the fludrocortisone. So you need to first rule out the presence of congestive heart failure or the fluid retention in these patients. We all know that it is a mineral corticoid agonist, and it causes a volume expansion. It increases the sodium absorption, and it is one of the most commonly used drug for the management of orthostatic hypotension. Drugs like ephedrine or pseudoephedrine or desmopressin have been also tried. Desmopressin is tried in both ways, nasal spray as well as the oral. But remember that the efficacy is very, very uncertain. This is what droxidopa and comparison to levodopa is, that you can see that the enzyme which is called as dopa deoxycarboxylase is responsible for conversion of droxidopa into norepinephrine. Remember the appreciate the hydroxyl group which has been added here, which has converted levodopa to droxidopa. So the first initiation is usually by fludrocortisone or flucortisone. We all know about it. Usually started with 0.1 milligrams per day and slowly increase to 0.3 milligrams. Do not cross. Usually best given in the morning time, but remember that you need to rule out congestive heart failure or supine hypertension or hypertension in this patient. Drugs like midodrine or droxidopa can also be given, but remember that droxidopa should be avoided, at the bedtimes. It should be always given in very early evenings, at around say 4 or 5 or minimum 4 to 5 hours ahead of the bedtime, to limit the possible supine hypertension it can lead to. If this doesn't work, then probably second line pharmacotherapy comes, where you are trying erythropoietin or methylxanthine caffeine or pyridostigmine or physostigmine. Sometimes NSAIDs can be also tried, but usually they are not effective as monotherapy. They are usually tried with the drugs like fludrocortisone or the sympathomimetic agents. Then if that doesn't work as well, then we do have a third line of pharmacotherapy. The latest approved drug is atomoxetine, which is a selective norepinephrine transferase inhibitor. Not available in India yet. Lupin has applied for the patent for this, and probably by the end of next year, probably we are likely to get this drug for the management. Vasopressin analogs like desmopressin or yohimbine. Yohimbine is one already been used. The dose is usually 5.4 milligrams. Somatostatin or ergotamine caffeine or even metoclopropamide. But remember that whenever you are using metoclopropamide, be very, very well aware about the extrapyramidal side effects. There are few devices like pacemakers or CRTs are tried, but they usually are only considered when the orthostatic hypotension is specifically secondary to a cardiac syncope. So this is overall management plan. How do you assess the patient in one shot? But my takeaway is the A, B, C, D, F of the primary prevention. And I believe this is my last slide. Number 1, A, abdominal compression. So wear an abdominal binder or a stocking which is coming up to the abdomen or a vest. B, bolus of water or bed elevation, especially on the bad days. Ask the patients to drink 2 8 ounces of or around 500 ml or half a liter of cold water prior to prolonged standing, and sleep with the head high with at least 4 inches up, as we have seen. Counter manures, like while standing, stand cross-legged or keep on trying the toe elevations as much as possible, or keep on bending or squatting occasionally. Drugs like midodrine or fluorocortisone, education and exercise, and finally fluids, because you need to stay hydrated very well to stop orthostatic hypotension. One investigational drug which is there is TD1955, which has been registered on the clinical government trial site. This is a norepinephrine serotonin reuptake inhibitor, NSRI, not yet approved, but probably has shown some promise. So to summarize, friends, postural blood pressure regulation is a complex phenomenon. We need to understand and appreciate it, as Dr. MUNJAL sir has rightly pointed out. It gets dysregulated with the age, and because of the variety of the reasons that we have discussed. Orthostatic hypotension is a common cause sometimes to cause significant affection of the quality of life and cognition, especially when it comes to elderly or high means very elderlies. It is also important to understand that it also impacts the morbidity as well as mortality of the patients. So proper management and the appreciation and the correct measures can prove pivotal to prevent orthostatic hypotension. Thank you very much for your kind listening. I will be very happy to answer any questions along with my team, if at all I have not confused you adequately.
Thanks, Mangesh, for a magnificent presentation. Truly, you did a wonderful job. Hats off to you, sir. Although Mangesh has answered most of our queries, but we have a distinguished panel of.
I would request Dr. NP Singh to join back. And,
Thank you, Mangesh, and I must say it is one of the very, very clear-cut presentation to the audience. Though we have very depleted audience, but still it was one of the very good presentation I encountered.
Certainly, sir. I request our chairperson, Dr. Ravikirti, to please introduce our distinguished panelist, Dr. NP Singh.
At the outset, my sincere thanks to all the respected seniors and the organizing committee for giving me this opportunity. It's an honor for me to introduce Dr. Narendra Pal Singh, who is a well-known person, as all of us are aware, who actually doesn't require introduction, but it's a customary. So presently, he is working as a professor of medicine and dean medical research at SGT Medical College Hospital and Research Institute, Budera, Gurugram. And before this, he was a medical director and as also an administrator. And he was also a senior director in the Department of Internal Medicine and academic head of DNB courses at the Max Super Specialty Hospital, Vaishali. And he was the director, professor, and head of the nephrology in the Department of Medicine at Maulana Azad Medical College, New Delhi. So he has got a outstanding clinical acumen and exceptional teaching skills, and he's got exceptional teaching abilities, and is a great administrator also. So I welcome Dr. MP Singh for the program.
Thank you.
Thank you, Ravi. Now, our next panelist is my close friend, Dr. JYOTIRMOY Paul. He's a professor in medicine, RG Kar Medical College, Kolkata. Dr. JYOTIRMOY Paul is a Dean-elect Indian College of Physicians. He has been the Vice President API and also past Vice Dean ICP. He has published numerous papers in national and international journals. I request Dr. Mangesh Tiwaskar, Dr. JYOTIRMOY Paul, and Dr. MP Singh to join for the panel discussion.
I also request Dr. Palani.
My first question is to Dr. MP Singh. Sir, although Dr. Mangesh has described very well the pathophysiology, but I would like your opinion about the pathophysiology of postural hypertension or orthostatic hypertension.
Thank you, Dr. Mathur. In 30 seconds, I would actually thank you for always inviting me and asking me to contribute certain things, but compliments to you and your team. Basically, we need to understand the normal physiology of standing. Now, please understand that whenever we stand, there is some amount of blood pooling in the lower extremities and the splenic veins, and it requires a hemodynamic response which consists of cardiovascular, neurovascular, and endocrine systems. So standing actually results in a pooling of approximately 500 to 1 liter in the lower extremity. This will initiate, as Mangesh pointed out, sympathetic outflow, which will increase the peripheral resistance. It will also increase the venous return. Cardiac output will be increased, and thereby limiting the decrease in the blood pressure. As a compensatory mechanism, please understand that these results in actually a reduction in systolic blood pressure of the tune of 5 to 10. So in a normal person, 5 to 10 millimeter of mercury reduction does occur. On the contrary, there is an increase in the diastolic blood pressure of around 5 to 10. Both these will maintain the mean arterial pressure, which he said, and there is an increase in the heart rate for around 10 to 25. Now, whenever orthostatic hypotension will result, which will because of the lack of one of the factors, it can occur in acute setting or a chronic setting. In acute setting, invariably it is because of the loss of intravascular volume, whether it is because of dysenteritis, whether it is because of the blood loss, whether it is again because of the cardiovascular hemodynamics. There is associated decrease in the venous return. There is inability to increase the cardiac output. Patient has a LV dysfunction, increase the cardiac output. Also, there are certain postural changes. All these will result in blood pressure reduction of more than 10 systolic and more than 10 diastolic. This will result in decrease in the blood flow to the cerebral circulation, resulting in the transient cerebral symptoms. And this is what orthostatic hypotension will result. So it's a combination of both cardiovascular dysfunction, the endocrine dysfunction, and the more important autonomic dysfunction that results in orthostatic hypotension. Obviously, elderlies do tend to have some amount of dysfunction in all the three. So it's fairly common among patients with elderly population. Thank you.
Thank you, Dr. Singh. I'll come to Dr. Jyotirmoy Paul. Dr. Paul, what are the clues in patient history for orthostatic hypotension? Are you there, Dr. Jyotirmoy?
He is unmute. He is muted. Jyoti, you are. If Jyoti is not there, I can answer it. But I think let's ask Jyoti. He's muted and his video is also off.
His video is also off.
Yeah, I think we, Dr. Singh sir, you can.
Dr. Singh sir, please, you can go ahead with the answer of this question.
So we need to look at the underlying etiology through the historical clues. If the patient has any evidence of bleeding. Now, many patients, young males come to us with a syncopal attack or orthostatic hypotension, and you find that they have a history of rectal bleeding. These patients ladies come to us with abnormal uterine bleeding, suggesting anemia as the cause of hypertension. Then, of course, elderly, especially when they do have stroke or they have, Parkinsonism, they have typical symptoms of bradykinesia, pyrolytic movement, and the stroke patient has aphasia, dysarthria. All this would suggest associated dysautonomia secondary to stroke and other things. Patients with burns, gastroenteritis, etc., will have intravascular volume as the etiology for the depletion. And of course, a patient with LV dysfunction, significant LV dysfunction, will have chest pain, palpitation, breathlessness on exertion. Patient with sepsis, in elderly especially, the fever and other symptoms may not be present, especially in dengue and other things. We've seen this patient presenting with a sudden hypertension. And of course, there are seropositive patients who can present with this dysfunction. So we have to have a high index of suspicion of risk behavior. And a patient with GBS, etc., multiple sclerosis, can have symptoms related to neurological symptoms. And as Dr. Mangeshkar pointed out, a heavy meal can be a indication of a postprandial hypertension. And of course, if a patient suddenly collapses, then we need to look for cardiac cause like cardiac arrhythmias and seizure, etc. So these are some of the clues in the symptoms which can give you a clue to the underlying etiology.
And in fact, just to add to it, Girish, if you permit me, if you really appreciate what Dr. Singh sir has said, and as you are rightly asked about the compensation, why in our ICCUs have you ever thought that we make our patients to lie down into Trendelenburg position and not exactly flat lying down? Is basically because even while just sitting from the lying down position can cause blood pressure change to around 40%. The cardiac output can go down to around 20%. But while you keep the patient in the Trendelenburg position, there is hardly any change in the cardiac output. There is hardly any change in the blood pressure. And that is the reason why this Trendelenburg position is also so beautifully accepted all over the world in the ICCU for the same reason, because these are all the measures to avoid this compensatory difficulties sometimes these patients can have, especially for after the prolonged bedridden situation or the lying down position. So it's very important. In fact, if you have really realized this, that during the COVID times, this challenge has really come up. And that is one area where probably we have done a little bit better, because all our ICU beds have a Trendelenburg position rather than patients lying down flat or even sitting position.
Thank you, Dr. Mangesh, and thank you, Dr. MP Singh sir. And before moving to the next question, from my core of my heart, I congratulate Dr. Mangesh Tiwaskar for a wonderful and amazing lecture on this very difficult topic in a very simplified way. And on behalf of scientific committee, I have a big thank you for accepting just in 48 hours before and presenting such a wonderful talk. So you really need a big round of applause for this lectures. Thank you very much, sir. Thank you, sir. So my next question is that in day-to-day practice, we are suspecting OH, but there is one term which we are very frequently using, that is head tilt test. So I request Dr. NP Singh sir, what is this head tilt test, by which how can we suspect, how can we diagnose it, OH?
Dr. Tiwaskar's presentation was marvelous. But I failed to find a importance of head tilt test in that presentation.
Yeah, I have
Probably
not
because of
mentioned
the
it. Yes.
fact that probably, you see, not many people are practically using it. I feel it's an important test, especially in certain high probability of patients who do not have a positive evaluation. There are certain group of patients where, despite of our initial efforts of trying to find out the etiology, we are not able to find that. And of course, there are a group of patients, elderly patients, who have significant motor impairment that precludes them from having a standing vital, vitals being obtained. And also, we need to ensure that Dr. Tiwaskar's medication effect needs to be seen. And these are some of the indications for doing a head tilt test. What is it basically? It is basically a moving sort of a trolley in which I really wonder if we could Tiwaskar could have shown a photograph of that. But basically, it's done in a quiet room with a normal 20 to 25 degree of temperature. The patient, as he rightly suggested, that patient should be resting in supine for 5 minutes, and there are certain on the chest there are certain belt which is put so that he is not able to move when he's tilted, and hemodynamics are measured. There is a blood pressure, automated blood pressure instrument which is there. There are cardiac monitors which are attached so that whenever the tilt test is being done, his hemodynamics are being monitored continuously, and the table is then slowly elevated to an angle of around 60 to 80, and that's what Dr. Tiwaskar did mention, that in the definition, apart from the checking your blood pressure, if you tilt the person to around 60 to 80 degree for 3 minutes, then if it is there is a fall of more than 20 and more than 10, then the test is considered positive. If symptoms occur during testing, then of course we should return to the supine position immediately. Now we can, based on the response of the tilt test, we can find out what is the underlying etiology of this so-called postal hypertension. In a normal person, as I said, the heart rate can increase to around 10 to 15 beats per minute, and there can be a diastolic blood pressure increase of 10. So if that occurs, that is normal tilt. And especially in dysautonomia. Oh, excellent. Thank you. In dysautonomia, there is immediate and continuous drop in systolic and diastolic blood pressure. We know that this amount of, and there is no compensatory increase in the heart rate because the sympathetic activity which is supposed to be compensating is not there. Then in neurocardiogenic syncope, you know that it's like there is a drop of blood pressure and simultaneously there is bradycardia as well. And that occurs around 10 minutes after testing of the head tilt test. There can be orthostatic hypotension where we have defined that there is 20 millimeter mercury of systolic and 10 millimeter diastolic depression. And as he also pointed out, there is a syndrome in which you have postal orthostatic tachycardia syndrome. So suddenly there is, due to dysautonomia, there is increase in the heart rate by at least 30 per minute, or there can be a tachycardia. So these are some of the responses to head tilt test. I tried to find out that where all these are available. Very sophisticated neurological centers do have head tilt test. But I remember I wanted to get this test done in one of my subjects. It was very, very difficult to get it done from even Max Hospital. But now probably things are improving and people are trying to get this test. Thank you.
Yeah, that is the reason why, sir, I did not show that actual picture because it's not so readily available. Even absolutely
and
very rightly pointed out
and other
that
factors can, and which you said that medication and all.
Correct. And in fact, most of the times, our clinical assessment has to be one of the pivotal things because these are all the things which are not so easily available. I had that slide, but I did not show that.
Thank you. Thank you. And your presentation was very crisp. Yes, I must compliment you.
Thank you very
wonderful.
much.
Wonders, wonderful.
Thank you, sir, for your this diagram, also showing this diagram immediately, prompt response. Thank you very much, sir, for explaining in a diagrammatic way. So I again moving to the next question to Dr. N.K. Singh, sir. I think this already described by Dr. Mangesh Tiwaskar. but I request your expert comments on this non-pharmacological treatment of orthostatic hypertension. I request Dr. N.P. Singh, sir, your comments, sir.
So I think it's a very, very important and very rightly stressed by Dr. Tiwaskar regarding, non-pharmacological measures, because pharmacological treatment may be associated with their own side effects and complications. So as I said, this orthostatic hypertension can be acute or chronic. And in acute, we know that the best way of treating it is to give IV fluids, give fluids as early as possible so that these patients recover. In non-pharmacological method for long-standing orthostatic hypertension, I think the first and the foremost important thing, as again was pointed out, was to ask the patient, give me your prescription. Now, instead of asking him what drug are you taking, you must ask him to show me your prescriptions. And as pointed out, there are various drugs, including sildenafil, including nitrates, including beta blockers, including so many medications which the patient and the treating physician may not be aware. So I think the first and foremost thing is to find out the potentially contributing medications, and of course many of them may not be discontinued. So obviously antihypertensive cannot be discontinued. So what we can suggest is that kindly take these when you are going off to sleep, so they can possibly take them at bedtime, particularly the antihypertensive. And also, I think one of the very important component of this is whenever you take a very high carbohydrate rich meal, and very again aptly pointed out by the speaker, there is a huge amount of splanchnic venous cooling. So tell them to avoid postprandial hypertension, especially, and avoid a rich meal. One good thing which has happened with these presentation is, one is, of course, we don't need to take mementos home, which is again a collection for Tiwaskar's limited accommodation, and more importantly, no alcohol is served. So alcohol should be avoided in patients with as a part of the non-pharmacological patients, especially elderly, and they should be encouraged to keep a symptomatic diary. They should consume, as rightly pointed out, especially in this situation, around 2 liters or 2 to 2.5 liters. Again, it comes with a warning that if the patient has an underlying CKD or something, we need to be careful. But a 2 liter or a 480 ml of glass of water, cold water with some 2 grams of salt, if the patient does not have a systolic hypertension, which is one of the very effective means to increase the blood pressure. And excellent photograph on that binders. That is an ideal abdominal binder which starts from the lower limb and goes up to the abdomen. And this has been shown in a randomized single-blind controlled trial using a head tilt test to be the most effective management strategies for such a chronic situation. Of course, there are certain maneuvers which have been told, a very good depiction, standing with crossed legs, or without leaning forward, squatting to alleviate the symptoms. There are certain maneuvers. I think what we see at 8 o'clock every day morning by the Yogi Baba, I think, but some of the yogic, methods have also been, especially the stretching exercises, etc., can help in such a situation. Abdominal muscles exercises, which again yoga can teach us, can give you a very, very effective method of, managing non-pharmacological ways. And I would feel that majority of these patients would be better off by altering their medication pattern and resorting to non-pharmacological. Thank you.
Thank you. Thank you.
It was one more point to add,
Yes,
here
yes.
as
I always leave 1 or 2 points for you.
I know. So is this that where alcohol must be avoided in the patients of orthostatic hypertension, but the patients, those who develop the reactive hypertension on lying down, that is the reversal of the circadian rhythm, circadian response. In this, probably a glass of red wine along with hydralazine has been shown to be very effective for the management of this hypertension, which is usually secondary to lying down.
So maybe in Jaipur, when we meet, I'm very sure that some of us, not me, will at least prevent that. The glass of red wine.
Red wine. Thank you. There's another point. So, to Dr. Mangesh Tiwaskar, sir, what is the role of diabetic autonomic neuropathy in developing postural hypertension? Because we often have a very high incidence of diabetes. We have a
Absolutely.
global capital of diabetes.
Yeah.
We have every 10th person is a diabetic. We have every third person is a pre-diabetes.
Yes.
And after the age 65, we are having every third person is suffering from diabetes. So how would you put it, sir?
Yeah, it is amazing question, sir. And we all know that diabetes is one of the causations for the orthostatic hypotension or autonomous neuropathy related challenges, and especially the cardiac autonomic neuropathy, which is sometimes have been proved to be one of the primary cause for the cardiac arrhythmias and the cardiac mortalities or the overall mortality in the patients of diabetes or sudden cardiac death. These are all the challenges which are there. And one of the simplest and the easiest test for diagnosing autonomic neuropathy, especially in the or presence or absence, is just to check for what we know as gustatory sweating. The patients there who do develop sweating just by even while having a regular normal non-spicy food, they'll start getting sweating over their head or sometimes on the forehead, or they have got very warm shake hands or wet feet or stinky socks. Patient entering in your clinic with a very stinky socks, and you see there he has the wet footprints on the floor, or they have got a very wet shake hand. These are all the patients, those who have developed autonomic neuropathy, especially, and that is simplest way of diagnosing it, apart from all these complicated tests. So diabetes is one of the commonest reasons for a development of orthostatic hypotension and the related complications. And whenever the patients have diabetes, you need to be a little more extra careful and watchful in evaluating these patients.
And
Thank you.
Dr. Mangesh, some common problems what we are encountering is orthostatic hypotension nowadays. Very common when you are using SGLT2 inhibitor because of dehydration. At the same time, we think that the diuretic, the loop diuretic alone will produce orthostatic. Not like that. Even chlorthalidone itself, thiazide like diuretic also in a very elderly individual, even 6.25 milligram also can produce orthostatic hypotension.
Yes, of course.
At bedtime, they want to pass the urine at 1 o'clock or 2 o'clock. Suddenly, they are getting up, suddenly going for the bathroom, they will fall down and may produce sudden cardiac death due to arrhythmias. So usually in this situation, especially in the elderly individuals, changing the timing of that is antihypertensive drug which contains chlorthalidone. Usually I used to prescribe in the evening dose. That's 5 o'clock or the 4 o'clock or 5 o'clock or 6 o'clock. When the patient go for the bed at 10 o'clock means you change the timing. It's also it will prevent, and adequate hydration is very, very important nowadays. SGLT2 inhibitor, the very elderly individual, the complaints is poor because of inadequate hydration. Inadequate hydration will suppress the brain center, the satiety center, that is a hydration center. They will get depression, anxiety, other things. They forget to take a lot of waters, plenty of waters. So nowadays, chlorthalidone as well as SGLT2 inhibitor, the first 1 month period, chances of getting orthostatic hypotension is very high because of purely because of dehydration as well as hyponatremia. That point we have to give very important cause of orthostatic hypotension. And the first 1 month, usually my patients avoid, that's already the patient is having salt restriction. Please avoid salt restriction when you are using SGLT2 inhibitor for the first 1 month. After that, slowly you can update it. You can down titrate or update the drugs as well as the salt restriction. This is my practical experience I want to share.
Dr. Panelippan, my last question is to Dr. Jyotirmoy Paul. Could not join us because of some technical reasons, I think.
What are yes, you can join now. Yes.
What are the important physical examinations in evaluating orthostatic hypotension?
Yes, this is very nice because this is important from our clinicians' point of view. What I can say, when you will get the patient of orthostatic hypertension, divide into two ways, either acute presentation or chronic presentation. In chronic presentation or acute presentation, you can, in both ways, you can divide into two parts, with neurological, without neurological. Because one group is idiopathic and diabetes, very common, or due to the aging itself. As in other cases, you will get some of the disease. We can identify some disease which is correctable and which is not not correctable. Maybe some.
Please unmute. Jyoti.
Jyoti, unmute.
Unmute. So multi-system atrophy. So whenever we get a patient with orthostatic hypotension, divide into two parts. Acute, if it is acute presentation, you search for the Guillain-Barré syndrome or botulism or porphyria. These are the very hello.
Yes.
Or patients with dehydration. When you will get a chronic onset, apart from dehydration, you search for the stroke, whether patient has long-standing anemia, some cardiovascular disease, some Parkinson's disease, some HIV. So these are the presentation for the chronic presentation.
Thank you, Jyoti.
Thank you. There is a lot of signal problem here due to rain.
Yeah, I can understand. There's some technical issue. Dr. Mangesh, there's a question in the chat box. Is
Yes,
there
sir.
something like orthostatic hypertension?
Yes.
Oh yeah, Dr. Parikh, sir.
Orthostatic hypertension.
Yeah, that is what we know as NP Singh, sir. You would like to take it? Yeah.
It's a very, very favorite question of mine, in fact,
Yes,
to the
I know that.
students. When you have you see, as I said in the pathophysiology, whenever one stands, there is a pulling, but there is a decrease in the systolic blood pressure, but there is a, because of vasoconstriction and all, there is mild increase in the diastolic blood pressure. So whenever you have an exaggerated, sympathetic activity, there are patients who are very anxious. There are patients who actually have anxiety in their blood. So obviously they have a chronically elevated sympathetic overactivity, and whenever they stand, there is an exaggerated response to the postural drop, and these patients tend to have, orthostatic hypertension. I hope, Tiwaskar, am I right or
Yes,
no?
absolutely. Because this is one of the ways. This again is a part of autonomic dysfunction, where you rather than having a compensatory, absolutely precise sympathetic compensation, there is a sympathetic overdrive which is happening or which is over. This also sometimes, if it happens at night time, we popularly know it as reverse dipping. This is one of the reasons for, in fact, the strokes especially and the cardiac arrhythmias. That is the reason why early in the morning, you get highest amounts of myocardial infarctions and strokes, especially in the wee hours of the day, where there is, from the 4 o'clock in the morning, the whole hemodynamic starts changing.
So again, I feel yoga is one of the very, very good non-pharmacological means by which we are able to control our, autonomic system through very, very graded and improved physical activity.
Usually 12 to 2 o'clock, 10% low in the baseline. 3 o'clock to 9 o'clock, 10% rise in BP. Usually, no, Mangesh? Because of counter-regulatory hormones.
That is what is called as a normal circadian rhythm. This is a normal circadian rhythm. But then you do have got dippers. There are excessive dippers. Then there are non-dippers, and then there are something called as reverse dippers, where they have got an accelerated response. So rather than blood pressure dropping, the blood pressure shoots up there.
Yeah, BP rises.
The BP shoots up there, and that is one very, very difficult condition to manage.
Thank you, sir. We had a very wonderful presentation by Dr. Mangesh Tiwaskar, followed by an equally excellent panel discussion by our panelists, Dr. NP Singh, Dr. JYOTIRMOY Paul. I request our mentor, Dr. KK Parikh sir, for his concluding remarks and vote of thanks.
Thank you, Dr. Mangesh, for a very masterly presentation, and especially when you've been requested to, within a very short period, we asked you to prepare this presentation. I mean, if you would have told you 15 days back, I think that what should have been the presentation. So it is really a great presentation. Thank you so much, and a wonderful discussion. Thank you, Dr. NP Singh, Dr. JYOTIRMOY Paul, Dr. RAVIKEERYHY, Dr. PALANIAPPAN, everybody, Dr. MUNJAL, Dr. RAJESH UPADHYAY, for sparing their valuable time for this webinar. Thank you, everybody. Thank you so much, and good night.
Thank you.
Thank you.
Good night. Thank you for the honor, sir. And it was a privilege, Girish. I appreciate. So
Really good.
thank you very much.
I
Thank
mean,
you,
sir.
Mangesh. Thank you so
Thank
much.
you very
Thank
much.
you.
Good
Thank you so much.
I dedicate this presentation to you all and especially to Dr. Singh, sir, because I know how much passionate he is on hypertension. And I would have, in fact, loved to hear him, and I being in the students gallery sitting and, gathering some pearls of the wisdom. And thank you, Ravi, thank you, Palani, and everybody. Thank you, Sharma, sir, Munjal, sir. Thank you very much for, bestowing this honor on me. Thank you very much. Bye-bye. Good night. Stay safe, stay happy. Thank you very much.
Very nicely finished by 9:30. That's great.
Correct.
Thank you.
Yes.